Hello everyone, welcome back to my channel MedPath with Piyush. And today we are going to talk about a really important topic, that is thyroid hormones. And we are going to discuss it in three sections, maybe two. But today it's the time for the first section where we talk about general introduction to thyroid hormones with its clinical mechanism of secretion, regulation of secretion, and synthesis and metabolism. So let's start without any further ado. So coming on to thyroid hormones, there are three hormones that are produced by thyroid. That is T3, that is triiodothyronine, T4, that is known as tetraiodothyronine, or in common terms known as thyroxine, as well as calcitonin. T3 and T4 are secreted by thyroid follicular cells, and calcitonin is secreted by parafollicular cells. How you should get this is like in a diagrammatical manner. Like consider if these are two follicles and these are lined by follicular cells. Just giving you a rough example. Okay, so and in between the follicles there is filled is a colloid, right? So there will be these cells that are follicular cells. These will be producing T3 and T4, while in between these follicles you will find these cells. These will be known as parafollicular cells or interfollicular cells also in some books, and that means they will be secreting calcitonin. So that was the meaning of that. So let's move further. Further, you should know that thyroxine is the first hormone to be synthesized in laboratory. Many people get this MCQ wrong, giving its answer as insulin. But it's wrong. The first hormone to be synthesized in laboratory is thyroxine. Coming to potency, T3 is more potent than T4. What do you get from this is that to produce the same effect, if they both are producing 50% effect, T3 is required in less amount to produce that much effect. So that is why its potency is more. Okay, coming to chemistry and synthesis. In chemistry, T4 is known as thyroxine or tetraiodothyronine. That means it has 4 iodides attached to it. And T3 is known as triiodo. That means there are 3 iodine attached to it. So how you should learn this is like, learn just 3 and 5. There will be 3, 5, 3 prime and 5 prime positions. Okay, you have to just learn this. Now, how do you learn this formula? That is 3 and 5 will be there in almost everyone. Okay, 3 and 5 will be there in everyone. Now you have to choose. In tetraiodothyronine there will be 4 things required, so that means all will be there: 3, 5, 3 prime and 5 prime. But in triiodo you have to eliminate one. So for that you have to remember the deiodinase. There is an enzyme that we will study further, this deiodinase, and the enzyme that is found here is 5 prime deiodinase. That means 5 prime will be eliminated, and that means we'll find 3 prime here instead of 5 prime. Okay, that derived. Now tetraiodothyronine, if you will study it in somewhat detail, you know that the amino acid that is forming it here is tyrosine. Okay, so please remember it. It's tyrosine. Many people get confused with tryptophan, so tyrosine it is. Okay, so what I want you to learn here is the number of prime positions decreases the activity of hormones. Okay, this is very important concept that most people don't actually know why T3 has more potency than T4. That is why T3 has more potency and has more activity than T4, is because it has only one prime position, while thyroxine has two prime positions. So two normal position and two prime positions will get at a net of zero activity. Although it's not zero, I'm just giving you an example. Here it's 2 and 1 prime, so it's one activity. So that is why T3 is having more activity than T4. Okay. Now coming to its mechanism. Firstly, I'll teach you in general, and then we'll just go through a notes in somewhat of fast detail. Okay. So understand the whole mechanism in this one slide only. Okay, so first there is iodine that we take up, and it's converted into iodide in our body. Now this iodide will be taken up by thyroid follicular cells. Okay, this is a follicular cell that you are seeing. Thyroid follicular cell will take it up. Now we will think, why only thyroid follicular cell is taking it up? Why not any other cell is taking it up, in such a fast detail, because of one importer, that is NIS. NIS is sodium iodide importer. You should know this. Okay, because it is an important one. When we'll come to our pharmacology, this video is much more based upon general introduction to thyroid pharmacology. When we'll come to the drugs, you should know such points. Okay, because these are the points where the drugs will be acting actually. Okay, that they will be acting on NIS, they will be acting on pendrin, they will be acting on thyroid peroxidase. Okay, so you should know about this. So once the iodine comes inside with the help of sodium and iodide, that is why they are same porter, because they are both being pulled in, it's trapped inside. So that is known as iodide uptake or trapping. So iodide is coming here. I'm sorry. Okay, so iodide is coming here, and now it needs to be, you know go towards colloid. Okay, for going to the colloid, at its apical surface it has a protein known as pendrin. If you have studied from physiology well, you will already know about this pendrin protein. Okay, so iodide is now in the colloid. Now there is a substance in thyroid follicular cells that is known as thyroglobulin. Thyroglobulin, that is a very important substance that is known as TG, that you will find here. So TG comes into the colloid. Now, with the help of thyroid peroxidase enzyme, what happens is there occurs oxidation of iodide. Iodide will get oxidized into iodinium ion. Okay, HY is hypoiodous acid or hypoiodate, and EOI is enzyme linked hypoiodate. You don't have to learn everything. You just learn that from I negative there is formation of I plus. Just from iodide there is formation of iodinium ions. Okay, just learn this much. Okay, then this iodinium is mixed up with thyroglobulin. Okay, once it is mixed up with thyroglobulin, that is known as iodination, because iodine is now attached. Thyroglobulin is iodinated. If one iodine is attached, it is known as monoiodotyrosine. Okay, this is the tyrosine molecule we were talking about, that it is derived from tyrosine amino acid. Okay, it will be known as monoiodotyrosine. And if two I plus are attached, it is known as diiodotyrosine. Okay, so it's the formation of MIT and DIT. The next step is coupling. Coupling is joining something. Okay, so if MIT and DIT combines, mono plus di, 1 plus 2, the formation of 3, that is T3. And if DIT plus DIT combines, that is 2 combined with 2, that forms 4, that is T4. So that results in formation of T3, T4, and there is also some left of MIT and DIT that you will see ultimately here on this thyroglobulin molecule. So you get it. That is how the formation of T3 and T4 takes place, and now this T3, T4, MIT and DIT will be stored here in the colloidal stage, in colloid. Okay, the storage will happen here. When now there will be any stimulation by TSH comes and stimulate these thyroid cells, then there will be endocytosis of this particular thyroglobulin molecule. Once being endocytosed, it will go into the lysozyme and there will be lysosomal proteolysis. That means destruction of this thyroglobulin molecule. Once it has been destroyed, there will be release of T3 and T4, and MIT and DIT will be deiodinated to give back the leftover iodine to be used again. So iodine that was left, that was formed, that was left in the form of MIT and DIT, didn't form T3 and T4, that will be again gone via pendrin protein into the colloid, while the T3 and T4 will be secreted. Once secreted, I have told you that out of T3 and T4, the activity of T3 is much more, potency is much more. The main active form that acts in the body is T3. So T4, when will it go to peripheral sites like liver, kidney and salivary glands, etc. It is converted to T3 via a deiodinase that I have already told you by the formula that it is 5 prime deiodinase. And there T3 acts and produces the metabolic effects of thyroid hormone. Okay, so that in all was everything that we will find further written, right? So iodide uptake that I've told, okay, it is about 1/5 or 20% of total iodine is there present in thyroid cells. Why? Because symporter, the sodium iodide symporter or NIS. Okay, because of this NIS, there is more and more iodine taking up by thyroid. So that is iodide concentrating mechanism, but is not just peculiar to thyroid. What you have to understand is I told only 1/5. It is not only peculiar to thyroid, it is also there in skin, salivary glands, gastric mucosa and intestine. But the uptake is not stimulated by TSH in these organs. Okay, it is only stimulated by TSH in thyroid. Okay, that is obvious. It's thyroid stimulating hormone. Okay, getting my point. Next step was oxidation and iodination. So I negative, as I told, was transported via pendrin and oxidized by thyroid peroxidase. This was an important step that we missed. The enzyme that was doing the iodination and was doing every step was actually thyroid peroxidase and H2O2. Please remember this. This can be an MCQ question. You have to write this enzyme when thyroid comes. Okay, thyroid peroxidase converts I negative to I positive, that is iodinium ion. Then thyroglobulin molecule comes and there is iodination. This step is also done via thyroid peroxidase only. Every step till coupling is done by thyroid peroxidase and H2O2. Okay, now there is formation of MIT and DIT as we have studied for in in the above picture. Now there is coupling. I have already told you coupling above. MIT and DIT will form T3 and DIT and DIT will form T4. Now coming to an important thing, that normally T4 produces much more than T3. Okay, in general, and then this T4 is converted into T3 peripherally via deiodinase that I told you. But if there is iodine deficiency, think yourself, if there is goiter due to iodine deficiency, there is less of iodine, so there will be less of MIT. Sorry, there will be more of MIT and less of DIT. Because there is less of iodine, so monoiodotyrosine, that is one molecule of tyrosine attached molecules, will be more than two molecules of iodine attached. So in such people, or people with such deficiency, T3 will be more, because if MIT is more, MIT plus DIT combination is much more possible than DIT plus DIT. Okay, so T3 will be more than T4 in people having I2 deficiency. Okay, now coming to storage and release, I have told you that storage is in there in interior of follicles, taken up by endocytosis. This lysosomal proteolysis. The T3 and T4 are released into circulation, and T4 is deiodinated to produce T3, while MIT and DIT are deiodinated, and iodide is reutilized. Okay, now coming to peripheral conversion, that is very important. Okay, so we have a ton of things to cover here, and please look at this part because this is important. See, in target tissues, they will always take up T3 from circulation. They do not take up T4. Okay, that is why T4 is converted to T3 peripherally. Okay, but there is an exception in brain and pituitary where they take up T4 and convert it to T3 within their own cells. Normally, there are some peripheral conversion sites where T4 is converted into T3 and then the T3 is taken up by all of the cells. But brain and pituitary does this by themselves. They will take up T4 and they will convert it into T3 within their own cells. Okay. In general, the peripheral conversion is done in liver and kidneys. Liver is the primary site. Okay. You know this very well. That liver is a primary site for this conversion. Okay. Almost equal amounts of P3 and RT3 are produced when there is peripheral conversion taking place. Now, what is this RT3? It is reverse T3. So let's study that. There is T4. It has 3, 5, 3 prime and 5 prime. Okay. So deiodinase has different types. Deiodinase can be 5 prime deiodinase or 5 deiodinase. Okay, if 5 prime deiodinase acts, this formation of T3, that is 3, 5 and 3 prime. But if 5 deiodinase acts, there is formation of 3 prime and 5 prime. And now if you see, please look at here. There is one normal position and two prime positions. 1 minus 2 prime, 1 prime. I already told you that prime position will decrease the activity. So actually 3 does not have too much of activity. Okay, know that. Next up, coming to deiodinases, I already told you that there are different forms, 5 deiodinase, 5 prime deiodinase. Now, these are known as iodothyronine deiodinases, which are actually in three forms, D1, D2, and D3. D1 will generate both T3 and RT3. It means it has activity of both 5 prime deiodinase and 5 deiodinase. D2 will generate T3. That means it has activity of 5 prime deiodinase. And D3 will generate RT3. That means it has activity of 5 deiodinase. You should know this. Now coming to antithyroid, some drugs, we haven't studied them, but you have to know them here only. The antithyroid PTU, that is propylthiouracil. We'll study them when in the next coming videos. Propylthiouracil, not carbimazole, please note this. Carbimazole is also an antithyroid, but PTU antithyroid will inhibit D1. You have to know this. Okay, that will inhibit D1 and ultimately T3 will not be produced. That is why they are antithyroid. So this is one of the mechanism of action of antithyroid PTU. How it acts? It acts while inhibiting D1. Amiodarone is an antiarrhythmic. It's a potassium channel opener. If if you have studied CVS system, it's an antiarrhythmic and it will inhibit both D1 and D2, and it will ultimately also act as an antithyroid. Okay, propranolol, high dose propranolol, beta blocker, and corticosteroids, they will ultimately inhibit peripheral conversion. They will not let brain and pituitary convert T4, take up T4 and convert it into T3. Thus, they will also act as antithyroids. Okay, so that was it. Next, we come about to transport, metabolism, and excretion. See, what do you need to know about transport is that these thyroid hormones, they are very profoundly bound to plasma proteins. They have very good bonding to plasma proteins. They are avidly bound to plasma proteins. Okay, so there is very less amount of T4 and T3 that is there in free form. If you know from your physiology, the main active forms of hormones are the free forms, but there is very less of active form of T4 and T3 because of their avid binding to plasma proteins. So protein bound iodine, it is almost all present in thyroid hormone. If you take iodine and you bind it to protein, so which hormone you will see it most into is thyroid. 90 to 95% in T4 and rest in T3. Because I already told you that T4 is produced in much more amounts than T3. It is then peripherally converted to T3. But okay, getting my point, 90 to 95% of T4 and rest in T3, protein bound iodine is present. So binding is done to 3 plasma proteins that you need to know, especially in this particular order. That is because this is the decreasing order of affinity. So what is the affinity of certain proteins to thyroid hormones? The first is thyroxine binding globulin, that is TBG. It has the highest affinity to bind to plasma protein. Then is transthyretin. Remember it as transthyretin. It is thyroxine binding pre-albumin. Pre means it will come before. Okay, it will come before albumin. Okay, and lastly it's albumin. People mostly think that talking about plasma protein bonding, let's say albumin is the first, but no, it's actually last here. That is why this is very important to be remembered. Okay, now protein bound iodine levels will increase during pregnancy. Okay, this is in general that you have to know, that protein bound iodine levels will increase during pregnancy. But do you think there will be any effect of this on body? No, actually no. If you were thinking there will be effect if there is much more protein binding, you know, there will be no action. But actually there is no effect as concentration of free hormones remains unaltered. This is very important thing to be understood, that protein binding iodine is increasing. Okay, But T3 T4 free hormone concentration is not affected. That is why it remains unaltered and there is no effect. Please, it can be used as an MCQ question, that what happens to T3 and T4 effect in pregnancy, but PBI levels increase but there is no net effect on the body. Okay, now metabolic inactivation of T4 and T3, how it occurs. Primary site is again liver. Other sites are also there, that is salivary glands and kidneys, but major site is the liver. It is by sulfonation, glucuronidation, many things happen, and once it gets inactivated, it's secreted via bile, and also there is enterohepatic circulation that occurs. Once in liver, it is metabolized, released by bile, goes to intestine. It can be reabsorbed here to the liver. So entero because of intestine, and hepatic. So enterohepatic circulation occurs. Okay, in T4 and T3 hormones. That much you need to know. Now coming to plasma T half. Plasma T half for T4, the plasma T half is 6 to 7 days. It's more than T3. Means T4 will persist for more time in the body, okay, than T3. What do you need to understand by this is what will happen to the levels of T4 and T3 when there is hyperthyroidism and when there is hypothyroidism. See, you don't have to mug this up that it will be shortened in hyperthyroidism and prolonged in hypothyroidism. Automatically think by yourself, if there is hyperthyroidism, thyroid hormone increases metabolism, there will be faster metabolism. ठीक है, अगर फास्टर मेटाबॉलिज्म होगा तो T4 एंड T3 विल गेट इजीली डिग्रेडेड, क्योंकि फास्टर मेटाबॉलिज्म हो रहा है, जल्दी से वो इनएक्टिवेट हो रहे हैं लीवर से. ठीक है, सो दैट इज व्हाई उनका जो प्लाज्मा टी हाफ होगा इट विल गेट शॉर्टेंड व्हेन देयर इज हाइपोथायराइडिज्म. एंड अगर हाइपोथायराइडिज्म होगा तो मेटाबॉलिज्म स्लो हो जाएगा, मेटाबॉलिज्म स्लो हो जाएगा तो अल्टीमेटली प्लाज्मा टी हाफ विल बी प्रोलॉन्ग्ड. ओके, तो इसको रटने की जरूरत नहीं, इसको सिर्फ समझने की जरूरत है और इसको रट लो कि प्लाज्मा इसको भी रटने का तरीका बस बेटर ही है कि T4 में 4 बड़ा है 3 छोटा है, तो इसलिए T4 का प्लाज्मा टी हाफ ज्यादा है. सब कुछ T3 का ज्यादा होता है, एक्टिविटी, पोटेंसी, बट T4 का प्लाज्मा टी हाफ ज्यादा है एंड T4 की वैल्यू जो सिक्रेटेड होती है वो ज्यादा होती है. ओके, नाउ तो लास्ट टॉपिक ऑफ दिस वीडियो वी कम टू द रेगुलेशन ऑफ सिक्रीशन. ये रेगुलेट कैसे होती है इसकी सिक्रीशन. ठीक है, तो देखो ये एंटीरियर पिट्यूटरी, इसको जब हाइपोथैलेमस से टीआरएच सिक्रीट होता है, दैट इज टीआरएच इज थायराइड थायरोट्रोपिन रिलीजिंग हार्मोन. ठीक है, थायरोट्रोपिन रिलीजिंग हार्मोन, इसका मतलब है कि थायरोट्रोपिन को रिलीज करो. थायरोट्रोपिन इज व्हाट, टीएसएच. तो अल्टीमेटली जब हाइपोथैलेमस से थायरोट्रोपिन सिक्रीट होता है, इट एक्ट्स ऑन एंटीरियर पिट्यूटरी. ठीक है, वंस इट एक्ट्स ऑन एंटीरियर पिट्यूटरी, उससे टीएसएच सिक्रीट होगा. इन टीएसएच किस पे एक्ट करेगा, थायराइड पे, और उससे T3 एंड T4 सिक्रीट होगा. ठीक है, वो कैसे सिक्रीट होगा, वो सारी बात अभी तक हम करके चुके हैं. ठीक है, कि अगर TSH होगा तो आयोडीन का अपटेक होगा NIS से, अल्टीमेटली उसकी एंडोसाइटोसिस होगी, उसका सिक्रीशन होगा. ठीक है, वो सारी बात हमने करी. व्हाट यू नीड टू नो इज कि जो TRH एक्ट कर रहा है वो GS मैकेनिज्म से कर रहा है, मतलब CAMP मैकेनिज्म से एक्ट कर रहा है, वाइल जो TSH एक्ट कर रहा है वो GS और GQ दोनों मैकेनिज्म से एक्ट करता है, यानी कि CAMP मैकेनिज्म से भी एक्ट करता है और कैल्शियम और PIP मैकेनिज्म से भी एक्ट करता है. ठीक है, अब अगर हम इसके रेगुलेशन की बात करें तो देखो, अगर T3 एंड T4 ज़्यादा प्रोड्यूस होगा तो खुद से सोचो, देयर विल बी नेगेटिव फीडबैक. बहुत ही सिंपल एंडोक्राइन फिजियोलॉजी है. ठीक है, कि देयर विल बी नेगेटिव फीडबैक, तो वो फीडबैक एंटीरियर पिट्यूटरी को भी जाएगा, जिसकी वजह से TSH कम होगा, दैट मीन्स इनिबिशन, और वो चीज़ हाइपोथैलेमस को भी जाएगी, जिसकी वजह से TRH कम होगा. ठीक है, अल्टीमेटली देयर विल बी डिक्रीज इन T3 एंड T4. साथ ही साथ हाइपोथैलेमस क्या करता है, वो एक हार्मोन रिलीज करता है, सोमैटोस्टेटिन. अगर आपने इन जनरल इंटीरियर पिट्यूटरी हार्मोन्स पढ़े हों तो उसमें बताया था मैंने, जब हमने ग्रोथ हार्मोन की बात करी थी, कि जो सोमैटोस्टेटिन है वो ऑलमोस्ट हर हार्मोन को इनहिबिट करता है इंटीरियर पिट्यूटरी के. ठीक है, इट इनहिबिट्स ग्रोथ हार्मोन एज वेल, it inhibits prolactin as well, it is inhibiting TSH as well. अगर हम पेनकेस की बात में जाएंगे तो it will inhibit insulin and glucagon secretion as well. ठीक है, तो सोमैटोस्टेटिन is inhibiting via via hypothalamus secretion to inhibit TSH. तो सोमैटोस्टेटिन यहाँ पे TSH को भी inhibit करता है, that is also one way of regulation of secretion. एक और रेगुलेशन ऑफ सिक्रेशन कैसे हो सकता है, आयोडाइड के खुद के लेवल से, कि बॉडी में आयोडाइड के लेवल कितने हैं। तो इसके लिए प्लीज याद रखना कि अगर आयोडाइड के जो लेवल्स हैं ब्लड में वो बढ़ जाएं, सोचो आयोडाइड ब्लड में बढ़ गया तो लोग सोचेंगे कि और आयोडाइड अपटेक होगा NIS से, और आयोडाइड अपटेक होगा तो T3 and T4 बढ़ जाएंगे, बट ऐसा नहीं है। अगर आयोडाइड लेवल बढ़ेंगे तो अल्टीमेटली वो क्या करते हैं, वो अपने ही अपटेक को स्टॉप करते हैं, इनिबिट करते हैं NIS से, और वो TSH का जो रिस्पॉन्स है उसको भी कम करते हैं। दे विल accentuate TSH response to thyroid and they will inhibit their own uptake via NIS, क्योंकि वो बढ़ गए हैं। कंसिडर इट एज एन फीडबैक मैकेनिज्म ओनली, कि अगर आयोडाइड बहुत ज़्यादा बढ़ गया है तो इसका मतलब है कि वो अब अपने काम को इनहिबिट करेगा, वो अपना अपटेक नहीं होने देगा। तो अल्टीमेटली दिस विल डिक्रीज इन प्रोडक्शन ऑफ T3 and T4 rather than इंक्रीज, जो कि हम नॉर्मली सोच सकते हैं। ओके, so guys, that was it. That was for the first part of thyroid hormone pharmacology. आई होप आपको ये वीडियो अच्छी लगी हो। अगर वीडियो अच्छी लगी तो प्लीज़ लाइक शेयर एंड सब्सक्राइब, और कमेंट कर सकते हैं आप अगर आपको कोई भी स्पेसिफिक टॉपिक पे वीडियो चाहिए। जहाँ तक थायराइड हार्मोन फार्माकोलॉजी की बात है, इसके आगे के पार्ट्स रिलीज होते रहेंगे, बट प्लीज़ गाइस डू सब्सक्राइब द चैनल अगर आपको ये अच्छा लगती है वीडियोस, ताकि आई कैन गेट मोटिवेटेड टू मेक मोर वीडियोस। ओके, टिल द नेक्स्ट वीडियो, बाय बाय।